Hello, in this video lecture, we're going to be talking about how we can apply some of these coding concepts to neoplasms. We'll be talking about coding soft cell cancers and other concepts. And again, the neoplasm table is in 7 columns. The leftmost column is the site of the neoplasm or the cancer, and the next 6 columns are also important. They will tell us whether the cancer is a primary, secondary, in situ, benign, uncertain behavior, and unspecified behavior. And all these are important for driving what code we'll be using. Let's take a quick look at the neoplasm table. And again, please pay special attention to these guidelines. I'd strongly advise all of you to look at these guidelines in every chapter, but especially this one. This one's going to be very critically important. And they usually appear right at the beginning of the chapter. Read these things very carefully, and I think you'll have a much better understanding of what's going on. Now onward to the neoplasm table. Just like in your code book, your textbook has them in the columns. We can have malignant primary, malignant secondary, malignancy or a cancer in situ, benign, uncertain behavior, and unspecified behavior. And as you can see here, all these are different codes. So very important to get a handle on that and read the documentation carefully. And anything with the dash, we need to pay special attention to because that means that there's going to be a 5th character for laterality. You'll get that 5th character by validating the codes in the tabular. Every time you do any type of ICD-10-CM diagnosis code, assign any code whatsoever, you should always validate it in the tabular, but it's especially important here. With ICD-10-CM and cancer coding, we look at 3 different things that drive codes. First is the topography, the histology, and the morphology. The topography we've already looked at with the region. It's the specific part of the body. The histology is the study of the cell structures. And sometimes with a histological term, it kind of gives the code, such as malignant melanoma. And then the morphology is the physical shape or size of the cancer. And again, as we talked about, we always need to validate the tabular. When you see something in the alphabetic index with a dash, that's a cue that we need to pay special attention. In this case here with C50.411, the 1 is going to tell us whether it's the right female breast or the left. Likewise, benign neoplasm of the left kidney, we look at that 4th character of 0, and it's going to tell us it's on the left. We also have codes for unspecified or bilateral locations. Here's how we put it all together. When coding cancers, if a morphology is stated, we have to locate the morphology of the tumor in the index to diseases. What we mean by using a morphological term or morphology, start by looking at anything that ends in OMA, lipoma, melanoma, sarcoma. All these will direct you to specific codes that are in the index. Not every entry with a morphological term is going to have a code right out of the index. For example, glioma will direct us to see neoplasm uncertain behavior by site. So that's where we get back to the neoplasm table. If the morphology is stated, but the physician doesn't include a site, the coder should look and locate the morphology of the tumor in the index. There's certain types of morphology that automatically, by their definition, include a site as the only possible place where the tumor would develop. An example of this is the serous papillary carcinoma. It has an entry for an unspecified site, and the code is C56.9. And the coder has to go ahead and trust the index, as this type of cancer will only occur in the ovary. The coder is uncertain about the behavior of a neoplasm. For example, carcinoma is always a primary malignant tumor. Need to make sure that when you're looking at the neoplasm table, you know the site of the neoplasm. That's one of the drivers of the correct code. There are a lot of instructional notes that are important to review in addition to the code. So you can't stop reading once you've validated the correct code. There are notes in the tabular that will tell you to identify such things and code such things as alcohol abuse, alcohol dependence in remission, tobacco dependence, history of tobacco use, and others. And you see an example of this under code category D3A. Again, when we say code category, we're talking about the first three characters. So with a benign neuroendocrine tumor or a malignant neuroendocrine tumor, there are two notes that tell us to code any multiple endocrine neoplasia, or to also use additional codes to identify any associated endocrine syndromes such as carcinoid syndrome. We talked about the neoplasm table. We talked about the difference between primary and secondary sites. And now I'd like to spend some time talking about some of the soft cell cancers like leukemia, lymphoma, multiple myeloma. These are considered systemic in nature, and they don't metastasize in the same way that other cancers do. Again, we covered malignant neoplasm, the neuroendocrine tumors, right? So important to read all the instructional notes associated with these. Again, one of the things that talks about the primary site, how do we know something's a primary site? The primary site is where the tumor originated. Once it spreads somewhere else, it becomes a metastases or a secondary site. And this is what the pathologist can see when they do a biopsy of it. There's a specific guideline that talks about two or more contiguous sites, and I'll let you read that. But in some cases, one of the more obvious ones that we see is sometimes we'll have a malignant primary of the jejunum and the ileum, or the ileum and the cecum, right? So we have point 8 to kind of talk about that overlap. We talked a little about secondary sites, but figure 5.2 illustrates how these metastases occur. And you see some of these in textbooks about how the cancer will grow from outside of the primary site into the lymph nodes, into the bloodstream, and then spread. So a common thing with breast cancer is we can have breast cancer that metastasizes to the bone, to the brain, to the lung, and so on. Some other sites that we see with metastases are the bone, the liver, the lung, and sometimes we see a new primary. A new primary happens when a patient develops cancer a second time, and it's unrelated to the first cancer site. Typically, these will look different to the pathologist when they do a biopsy. So the providers will determine whether something's a new primary or metastases. A patient may have a metastatic tumor, but sometimes we can't find the primary, or we're unclear on where the primary was, right? Sometimes the patient is a poor historian, right? So we would at that point use a code for a primary malignancy unknown site. And again, table 5.2 in your text will talk about some of the more common primary sites and main sites of metastases. Of course, we don't always see providers using the term metastases or secondary. Sometimes they'll talk about extending to, direct extension to, metastatic to, invasion through. All of these are terms that are saying basically the same thing. It's a secondary tumor or metastases. So in this case, we have metastatic carcinoma of the colon to the lung. So we need to code the primary, the C18.9, and then we code the secondary C78.00. We talked about spread extension two, so very important to read all of the documentation to look to see if something is secondary by looking for some of these related terms. Secondary to, extension to, spread to, invading, invasive of. Now we get into the lymphatic and hematopoietic tissue. In the last week of the course, we're going to talk about some new guidelines on this, but for the purposes of this and to get people on the same page, we're going to stick strictly to the information in this section. A lot of times people call these cancers soft cell cancers, right? And they're basically three types. The lymphomas that arise out of lymph tissue, the multiple myeloma that comes out of bone marrow, and leukemia, which forms in the abnormal white blood cells or the leukocytes. All these conditions are considered systemic, right? We might have it on both one or both sides of the diaphragm, but there's lymph cells throughout the body, so it's considered a systemic disease. So we don't talk about these or classify these in terms of metastases in the same way that we do other cancers. With lymphomas, there's again some new guidelines and new codes on lymphomas, but they're classified broadly to the type and the specific lymph nodes that are involved. Multiple myeloma is classified whether it's in remission, in relapse, or not having been in remission. And then leukemia, in a similar way, is classified as to remission, in relapse, or not having achieved remission. What do we mean by remission and relapse? Remission is when symptoms are absent and the disease seemingly goes away, or when they decrease and require less or discontinued treatment. When we have a relapse, we have a return of all the symptoms after an interval of the symptoms being gone. Could also use the term recurrence, meaning the same thing as a relapse. Something that is another thing we want to make sure that we pick up if it's the documentation supports it is neoplasm related pain. People who have metastatic disease, especially to the bones, will have neoplasm related pain and need treatment or admission for it. And this is pain that's associated with having metastases. This could be either acute or chronic pain. And treating the pain either might be a principal if it's in an inpatient setting, or first listed if it's an outpatient setting for the reason for coming into the hospital or the medical office. If the reason for the admission or the medical office encounter is for management of the neoplasm and the pain is also documented, G89.3 is assigned as an additional code. So again, what you know the difference? It depends on what the documentation says. Why did the patient come in? If the patient's coming into the medical office for treatment of the pain and no cancer treatment is given, it'll be a first listed code. If they're admitted for pain treatment, it'll be a principal diagnosis. Again, we can't have principal diagnoses being used in an outpatient setting. And again, if we're treating the cancer and also the pain is documented, it's going to be a secondary code. And again, malignancy is normally used to describe something that's worsening, and typically in most contexts being used to describe cancer. Now, the last concept I'd like to discuss with you is current malignancy versus personal history. If you've taken reimbursement, you recall the HCC or Medicare Part C. This is very important to code these correctly because this data will determine whether a medical office and insurance company get reimbursed for active cancer versus a personal history. Globally, if somebody has had a surgical excision of a cancer, we have clear margins, they're not undergoing any treatment, it's considered a personal history, Z85.0 through Z85.7. So in other words, the cancer is gone, it's no longer an issue. History of. If they have active cancer, we would use the cancer code from the tabular. And again, this is covered in guideline 1.C.21 in your text. Please become familiar with it. And again, important couple of things to sum up. First of all, when you're coding these cancer cases, look to see if there's a morphological term, something ending in OMA. If there is, start in the index and realize that you may have to go to the neoplasm table. If it doesn't have a morphological term, go directly to the neoplasm table and look for it by site. Be careful as you go through the neoplasm table to look beyond the main organ or body system. Some of these will be subdivided into more specific body parts. Be sure and review the documentation to determine whether it is a primary, secondary, in situ, and what type of behavior it is. Always validate the codes in the tabular. If you don't validate something in the tabular, especially when coding cancer, it's very likely you will miss the codes. And then finally, be clear on what is history of cancer versus active disease. If somebody had malignant melanoma, they had it excised, clear margins, they're not undergoing any other treatment, it is history of. That would be one of those Z codes. If they're still undergoing treatment, then it's going to be a different matter. Then they have cancer, and it'll be one of the other codes we discussed earlier. That's all I have for you. If you have any questions, please reach out. Glad to help you as always. Bye now.